Welcome, and thanks for joining us. My guest today is Dr. Alan Taylor, the Chairman of Cardiology at MedStar Heart and Vascular Institute. Thanks so much for joining us.
My pleasure, Deborah.
So let's start off with a basic question. Why is it so important to pay attention to your heart health?
Oh my goodness. Well, we all have a heart, and heart disease remains the leading cause of death in the country, despite all the gains. And half of men in their lifetime will experience some form of cardiovascular disease, 1/3 of women. So it's so prevalent and common. And the good news is we have a long time to predict and work around it, and the medicines are changing, so we don't have to be afraid of that. We can actually really dent that. And over the years, heart disease mortality has been declining. So we're making progress. But it's important that we all lean in on this because it's so common and preventable.
Okay, so let's talk about some of the basics we need to know about preventing heart disease. There are some basic guidelines about knowing your numbers, and that primarily, I think, applies to blood pressure and cholesterol numbers. What are the optimal numbers, and are those the only ones we should be focused on?
Right. These days we know that heart disease is predicted through heart risk factors, and everybody's familiar with those. Like your blood pressure. Optimal blood pressure is below 120/80. And we target those numbers these days, and that's a change. We've moved the goalposts. We used to say higher was still okay. So there's a point. Cholesterol. Cholesterol is, everyone knows about cholesterol. Everyone has cholesterol level. Frankly, in the country, cholesterol levels are too high, and we become comfortable with these too high values. And the goalposts have moved again, and lower values are now advocated in both if you've had heart disease or not. So you have to know your numbers because the goals have changed. And now, for instance, if you have a bad cholesterol above 55 and you have known heart disease, it should be lowered with another medication. Good news there is we have new medicines that achieve those numbers. On top of those two, there's a lot of other things we can really prevent. There was a study called the Nurses' Health Study, and it showed that if we live optimal, people that in the Nurses' Health Study, women, if they lived an optimal lifestyle, had really no heart risk in their lifetime. The problem was only 5% of women lived that optimal lifestyle and had optimal risk factors. So we have to move towards optimal. And these days we're getting further into our understanding of heart disease with new risk factor measurements, things like different forms of cholesterol that we previously didn't measure and we're going to have treatments for. And that's very exciting. So altogether, you should know what your risk factor levels are. And the other thing is that they change through your lifetime. For example, women in the menopausal period, their cholesterol change, blood pressure elevations become more common. And so it's not static and you have to stay on top of it. And one point for today is that women in the perimenopausal frame of their life, their risk changes. So a lot to know, and it's important for everybody to know their numbers and stay on top of them.
We talk about risk factors. What about things like family history, your weight, your lifestyle, things like stress? How important are those in determining whether or not heart disease will be a part of your life?
Right. Great question, Deborah. It all matters, and everyone's a little different. Stress, for example, stress matters. It can double your risk of heart disease, but the stress that matters there is not a bad day at work. It's a bad day at work that is always a bad day at work. It's a financial stress. It's always financial stress. It's that stress you can't get out of. And so, but stress management is important. Optimal weight, that's a problem for us in the country, and maintaining optimal weight is important because weight shows up in so many ways, blood pressure, cholesterol, and so forth. So it's a complex mix of things, and everyone has a unique blend of risk factors. Family history is something that comes into genetics. And we're learning more about genetics and genetic contributions and can measure that these days. So no matter your situation, there's a pathway for you to lower your risk for heart and blood vessel disease in your lifetime. But there was a man named Willie Sutton, and there's a thing called Sutton's Law. And it says, they asked Willie Sutton, who was a bank robber 100 years ago, why do you rob banks? He said, because that's where the money is. And the point here is that these days we're taking all these risk factors and measuring and treating them, but we're actually looking at blood vessels themselves and just taking pictures of them and saying, do you have blood vessel disease? Because that's where the money is. That is what tells us if you do or don't have that. So that gets us into new ways to detect risk. Not just modeling it through risk factors, but actually finding out, do you or don't you have this disease, which is deterioration of your arteries through your lifetime.
So through imaging is really a huge focus right now.
Yeah, think of the paradigm of women in breast cancer screening. You know, you should know if you have a mammogram abnormality or not, and you can do breast self-exams, and you can know if you have a family history of breast cancer, but in the end of the day, you need a mammogram. And this is the analogy to heart disease. We can know if you have risk factors for heart disease, if your family has it in their history, but at the end of the day, everyone's a little different, and why guess? Let's just look inside of you.
I want to ask you about exercise because we're always told by our doctors and especially cardiologists we need to exercise. And I think people wonder, does that mean I need to be a marathon runner? Does that mean I need to, be doing cardio exercise all the time? What kind of exercise is best for heart health?
Yeah, it's a great question. Well, let me tell people something they probably don't already know, because this is where they may tune out and say, oh yeah, exercise, they're going to tell me to exercise again. Yes, exercise is important, but it only has to be moderate exercise most days of the week. You can do small bouts of exercise and they add up. So doing a vigorous 10-minute walk in the morning and a vigorous 10-minute walk in the afternoon, and something 10 minutes is 30 minutes of exercise. The other point that people probably don't know is that the best risk is when you both do combine aerobic activity, physical activity that gets your heart rate up. And the right level is if it's moderate. That is, you can carry on a light conversation while doing it. But weight training is also really important. This idea of strength training, and not heavy lifting, just toning. And individuals who combine aerobic and weight training actually have the best cardiovascular risk profile, because that muscle mass actually is really good for your metabolic situation.
And does it matter how old you are?
No.
How do you need more or less or anything like that?
Well, good question there. No, the recommendations are the same, but the intensity level is again tailored to your age. One thing that does change is the optimal number of steps per day. Some people focus on their steps, maybe through their watch or another smart device, and that's a nice way to track. But actually, optimal steps as you age, get over the age of 60 or so, is probably more in the 6,000 to 7,000 range, not in this 10,000. And it's nice to have goals that are realistic, because if a goal is too far, people they give up, they feel like they can't achieve it. So stay active, stay busy, add it up, add some weight training, and you're going to really optimize your risk profile. But you don't need to be running marathons.
Wanted to ask you a little bit about, we're hearing a lot about alcohol and its effect on your overall health and specifically your heart health. Can you tell us a little bit about what we understand to be new recommendations and how that affects our heart health?
Right. We all know that truly excess alcohol consumption is bad for heart health. The recommendation has always been, in current recommendations, 1 or fewer drinks per day is compatible with heart health. And it's across all spirits. Beer, wine, spirits are all okay. I think, though, these days we're getting more conscious about the calories we take in, the metabolic consequences of that excess calories and the alcohol. So people are cutting back, and I don't think that that's necessarily a bad thing. But talk to your doctor about the right amount of alcohol consumption for you. It's compatible with heart health, but excess is clearly not good for you.
Okay, that's good to know. Talk to me a little bit about the environment and how and if that plays a factor in heart health. Where you live, does that make a difference?
Yeah, I love this topic because, again, we're trying to teach today things they probably haven't heard already, give them something new to think about into their understanding of heart disease. And the answer is yes. What we know is that particulate matter, that is things that are in the air, from exhaust, from cars, car brakes, from and other environmental sources, floats around us, and it varies by zip code. Some zip codes have higher intensity of this particulate matter, others less. And actually, if you can match those zip code maps to actually heart risk, and cancer risk, which is tremendously interesting. And so we're starting to add in this idea of this social determinant of health, where you live, into our understanding of heart disease. So you can actually go onto a map. First you can go into your weather app and you can see what the particulate matter is in the air around you right now, and also historically. And that historic exposure is actually important. So it's not something, well, we can modify it if we focus on the environment, and I think we're all trying to do that. But we can also understand it in terms of our risk. Do you live in a city? Do you live in an urban area? And how much are you exposed to? So we're learning more and more about that, and it definitely plays into heart risk. How does it do that? This small particulate matter gets into your bloodstream and actually causes inflammation, oxidation, hurts your blood vessels. Quite interesting.
So if there is high particulate matter on a particular day, Do you recommend somebody would wear a mask that day or not be outside for long periods of time?
Yeah, the warnings you hear over your own airwaves, it's a code red day, are absolutely true. I used to, 30 years ago, I used to say, what's it matter? And we'd go for a run in the park. I wouldn't do that today, knowing what I know.
Let's talk about any new medications you mentioned, cholesterol medications. Anything else? What's on the horizon that people should be paying attention to, or that, when their doctors talk to them about it, they don't go, I've never heard of that before?
It's one of the most exciting areas we have right now. For a long time, we were pretty stagnant in prevention. We had standard blood pressure pills, statin medications for cholesterol, and aspirin. Well, these days, what has happened? We de-emphasize aspirin if you don't already have heart disease, because we find that the most important pathway is to treat your risk factors. The biggest changes have been around cholesterol and what we call metabolic drugs. In cholesterol, beyond statins, we have a whole new armamentarium of very potent, very safe medications that lower cholesterol dramatically and lower risk. And the sad thing is, while available for a decade, they're very underutilized. So if you have heart and blood vessel disease, you should really ask, is my cholesterol really as good as it could be? Because these days, you almost can't have an LDL or a bad cholesterol that's too low if you already have heart and blood vessel disease. And this idea that a statin alone is good enough is probably not correct anymore. There's one thing. The second is around metabolic things. And this fight against obesity and all its with GLP-1 drugs. These are the Ozempic, Wegovy, Mounjaro type drugs. We're learning extremely potent for a vast array of things. Not only do they improve diabetes as they started, but now we're learning they prevent cardiovascular disease. They lower blood pressure. They lower cholesterol. They actually are beneficial in sleep apnea and arthritis. You're seeing this whole host of health benefits attached to metabolic optimization. And so while they're sort of all the rage, they're definitely expensive. We need better pricing. We need access. But that's coming as options open up. And so that's a very exciting area to say we can finally start to get control of this metabolic situation. And a lot of cardiovascular disease is attached to the metabolic situation patients have, not just their blood pressure and cholesterol, but their weight and inflammation in their body and all these other things.
Wow, so interesting. I want to ask you about AI, artificial intelligence, because we're digging deeper into sort of new ideas and technologies on this episode. And I think AI, we've seen it become really important in the medical community. Talk to us a little bit about how you are seeing that as a resource to prevent heart disease or to diagnose or treat it.
Yeah, as a physician, I'm extremely excited about AI in cardiovascular medicine. There's so much information to assimilate, and tools to help us do that better will help us take better care of patients, learn faster, aggregate the information. But where are we starting to see it come into play? We're starting to see it come into play in the way we manage our practices, scheduling, for example, making scheduling easier for patients, less friction getting in, optimizing schedules, for example. But we're also seeing it come into play in areas such as better diagnosis. Things that there's a lot of variability in how we approach them, and we want to eliminate that variability. The simple reading of an electrocardiogram, for example. Tools that basically make that standardized and detect diagnoses or subtle things that the eye doesn't typically see. We're seeing those come into play. So we're seeing AI come into, and I think it's going to come in small ways. People think, it's just going to take over and be your doctor. I think what you can look for, if I'm for your listening public, I would say you're going to see AI come in little small things. And they're little ways that are going to help, but each is meaningful. And we're already seeing that happen today. I'll give you a great example of another way we're using it. For example, we're using what we now call ambient AI. So this is exciting. It's an app. It's on your phone, and as a physician, I open the app and I turn it on. And during our appointment, we just talk, and we had the exact conversation we're having now. I ask you questions about your health. In the end, I push a button, and it writes my note for me.
So you're not taking notes.
I'm listening and talking to you.
Yeah.
And the good news there is if I don't say it, or I don't ask you, it doesn't wind up on the note. We have a better conversation. I'm not looking at a screen the whole time. I'm focused on you, the patient. And it's really, as a physician, getting me back to doing what I love to do, which is hear about you, take care of you.
That's wonderful.
And that's called ambient AI, and it's already in use.
Okay. No distractions. You just get to have a chat with your patient, like
Yeah.
the old days.
Yes.
Okay, we talked about AI, artificial intelligence. Beyond that, can you talk a little bit about some of the newer trends in heart care in terms of less invasive procedures that we're seeing these days?
There's a massive trend in cardiovascular medicine now for ways to approach structural heart problems with your heart, and to fix them in less invasive ways. For instance, we can now replace every heart valve in the heart without surgery, with just a procedure that inserts the valve. And we've moved across the heart to all the valves now, and those are almost same day procedures or next day out procedures, which is an amazing change. And so, we're approaching heart valve. What's that leading us to do is to approach heart valve earlier and earlier in its heart valve disease earlier in its development, so that we can avoid negative consequences of those problems. So this constant search for simpler, safer, better is happening across all forms of heart disease, and less invasive procedures are a big part of that now.
And we've talked a lot about prevention and risk factors, and that applies primarily to younger people, middle-aged people who are worried about their cardiac health. What about older people and the approach to heart health for the elderly? Is it the same, or does it change in some way?
It's a great question, Deborah. There really is no difference as we're seeing. Some things do change. Sensitivity to medications, safety of medicines, and it's always right to keep track of that and to assess it continuously. But with safer, easier procedures, better medications, we're enabling ourselves to, as the healthcare community, to expand those medicines and treatments into the upper age ranges. So there's really almost no upper age range for any of this. If someone's in good condition and something can benefit them, we can go for it. We've done heart valve replacements in 100-year-olds, literally to enable them to live that last few years. And think of those last few years, quality time left with grandchildren, great-grandchildren, functional, living independently. A little bit means a lot at that, and the benefits can be quite large in that population. So, no, that's where advocacy really comes in, and we're in the sandwich generation, and we're taking care of our parents or helping take care of our parents. So, that's a perfect thing to do: advocate, think, ask questions. But there's no age exclusion here.
All right. Just finally, just to wrap up, I guess, what would you say that you're most excited about right now in cardiac health care, and what do you want patients to walk away with who are, sort of afraid to delve into their cardiac health and maybe haven't really established a relationship with their primary care doctor where they can have these discussions? Mm-hmm. What would you say?
The thing I'm most excited about, Deborah, is that as a field, we continue to improve on quality and safety. Because the most important thing first is to deliver high-quality care that's always safe for patients. And while we're not perfect, and medicine will never be perfect, it is getting much, much better. The gains in how we take care of patients, the right medicines at the right time, the right tests and the right person at the right time, safe medicine that doesn't cause, is getting better and better and better. And there's so much attention being paid to this, driven by outside sources and also driven by our desire to do that. And there's never been a safer time in medicine than today. And new tools are going to help us even go farther. So if you're a patient, that should be good news to say, yes, medicine is not perfect, but we really are moving the needle on quality and safety. In terms of risk factors, I think you can look over the next few years as really a massive change. Important disorders like heart failure, safer and better all the time. New medicines that are actually preserving and protecting patients' lives. Metabolic conditions, safer, better medicines, potent medicines that are actually moving the needle for the first time in ever to attack these problems. So it's never been a better time to be a patient. And the good news is with these new treatments and approaches, you need to stay in touch with your clinicians because they have the access to them. And ask questions. Don't be afraid to ask questions like, could my cholesterol be better? Is my blood pressure truly optimal? Are those drugs the right ones for me? Could I benefit from those? And if the answer is yes, great news.
Terrific. Thank you so much.
Thank you, Deborah.
I'd like to thank today's guest, Dr. Alan Taylor, the Chairman of Cardiology at MedStar Heart and Vascular Institute. I'm Deborah Feinstein, and for more information on this series, you can go to WTOP.com and search Get on Top of Your Health. Thanks a lot.